University of Louisville, Department of Radiation Oncology.
Yes, thank you so much. Okay, so sorry about that. This talk is not going to take that long, I don't think, so it was okay. We had a little delay. How many people here are still in school? Raise your hand. Okay, good, because there's going to be a lot of test questions today. So, what are the main treatments for cancer? Does anyone know? Anybody know anyone who's had cancer? What kind of treatment did they get? What? Chemo. Okay, so like drugs. What else? Surgery. Great. Okay. Anything else? Radiation. Oh my gosh. Okay. So those are the three main things that we think of when we think about cancer treatment. Okay. So surgical oncologists tend to do the surgeries. Radiation oncologists, that's what I practice, do radiation. And the medical oncologists, sometimes we just refer to them as oncologists because they do everything else, okay? They train in medicine and then they train in oncology, so they're like the big cancer doctor, okay? So I'm a radiation oncologist. I look at a lot of images. So today, what I'd like to do is talk to you a little bit about imaging. Oh shoot, what just happened? Don't worry. Oh, it did? Yeah. Well, what is happening up here? Okay.
You might just have to track it with this one here.
Okay, that's fine, whatever. Okay, so I have two objectives, just like the last talk. I want people to understand imaging. So imaging for yourself, imaging for your family members, how to interpret it, what it means when someone's gonna have imaging. And then I want you to learn about bone-directed treatment. So when cancer goes to bone, what options do we have to do the treatment? So if I press this, will it go?
Yeah.
Hold on, how about this?
Is this the slide show?
Yeah. It says your screen sharing is paused.
Oh my gosh.
I know, right? What about if we go to Zoom?
That's weird.
The other Zoom? You have two Zooms. Yeah, there we go.
Oh, here.
That's it.
That's it.
Okay. There we go. So how do cancer cells get to bones? So a lot of times you'll talk to people who have had cancer, their family members have had cancer, and you ask them what kind of cancer, and they'll say bone cancer. Most of the time, it's not bone cancer. Most of the time, it's cancer that came from somewhere else and it went to the bone. So largely, most of the time that it goes to the bone, it travels through the bloodstream from the primary site. So just like in the last talk when we were looking at tumor cell DNA in the blood, we think about tumor cells actually themselves going through the bloodstream. So leaving the primary site where the tumor started, going through the bloodstream, and then depositing in the bone, and then growing into tumors that cause problems, okay? So how do we find out if tumors get into bones, okay? The main way that we find this out is with imaging. So what kinds of imaging do you guys think about, do you know about? So shout it out. A CAT scan, MRI, a PET scan, an X-ray, how about, right? And so there's a bone scan, a DEXA scan, okay. So there's a lot of different ways that we can find out if somebody has a tumor in the bone, even before they know that they have it. Each type of imaging has its pros and cons. So just because your doctor ordered one specific test and you know of someone else who had a different one does not mean that that test is inferior. Sometimes we're looking for different things. So we'll often have people come in and say, I want a PET scan right now. Sometimes that's not the best test for what we're looking for. So these are the things we just talked about. So bone scans, X-rays, CT scans, PET scans, MRIs. Again, they all do different things. So what is a bone scan? Bone scan is something a lot of patients get early on in cancer, where we're trying to find out whether or not cancer cells have traveled to the bones. Sometimes when we know that they've gone to the bones, we still do a bone scan to see if it's responding to treatment. A radio tracer, so it's medicine is injected into the bloodstream, it circulates through the body, you lay flat on a table once it's circulated through, and then it images the body. And so this is kind of what that would look like. And this is an example of what a bone scan result or a picture would be. So where you see areas where the bone is darker, that would be areas where the bone is very active, okay? Doesn't necessarily mean there's going to be a bone cancer there or a metastasis there, but it is an area that's abnormal or active. So an x-ray, a lot of people are pretty familiar with x-rays, so they're quick, very quick, they're painless. You can have x-rays of pretty much any part of the body. So this is just an example of an x-ray. So on the left, you're going to see what they say is very subtle findings on an x-ray, where in the humerus or the arm bone, they can see some changes that look like there might be cancer cells there. You can see less than a month later, there's been a fracture at that location. So the x-ray was good, but it's really hard to see something that like a bone met on an x-ray. So sometimes we want to move on to more sophisticated imaging. So the past few imaging, so the bone scan, the x-ray, those are two-dimensional. So it's like a piece of paper, you're looking straight at it. We like a lot of imaging to be three-dimensional, okay? So just like you were mentioning, so CT scans, MRIs, PET scans, those things are three-dimensional. And when we look at pictures, it's not just one piece of paper. The piece of paper depends on the area, the picture that we're taking. So if you look here in the axial plane, if you imagine yourself laying down on a table and you're a loaf of bread, we're cutting you up into slices. So each picture is a slice of bread, okay? So that would be an axial picture, but we can look at pictures in a lot of different ways. And so the other two most common ways are going to be the sagittal plane, so straight through the body, or the coronal plane. And we can take lots of pictures in these planes, okay? So the first type of 3D imaging is a CT scan. So the CT scan often uses contrast, okay? So this does not have to sit in the body for any period of time. This is a pretty quick scan. You lay on a table and then you usually go through what looks like a donut. It's painless. So this is an example of the types of images you would see from a CT scan. So we talked about before, here's your slice of bread on the left, the axial, and then the coronal, so that's coming this way from the front to the back, and then the sagittal right through the middle. PET scan. So a PET scan is unique because you're injected with something that specifically travels to tumor cells. So the most common type of PET that we use uses something that tumor cells really like. Does anyone know what that is? Sugar, okay? So glucose, perfect. So glucose is attached to something that's mildly radioactive. It's injected into the body, and then it travels to areas that are highly metabolically active, really like sugar, okay? So when we look at PET scans, areas that are very active are gonna light up, okay? So in this example, you can see that a part of the bone in the spine is lighting up. So that indicates likely there's going to be a site of cancer there. However, you can see other areas light up too. So your heart lights up, your brain lights up. These are areas that use a lot of sugar. Okay, so we have to interpret these carefully. So this is another example of a PET scan. There's different ways to look at it, but what you can see is that in this person, there's several areas that light up that indicate that likely these are spots where the cancer has spread. So last but not least is an MRI. So MRI does not use radiation, it uses magnets to take imaging. And again, MRI is no better than a CT isn't better than an MRI, it depends on what we're looking at. And so MRIs are really great for looking at things like muscles and bones and joints. And I'm going to show you some examples later about spine lesions where MRI is really important. These exams take a little bit longer. You do get a special type of contrast specific for the MRI. A lot of people have problems with MRI because of claustrophobia. So it's usually a very narrow tube that you're in. They do have some open MRIs, but to be honest, the imaging is far inferior. So this is just an example. And so in this example, we're looking at the shoulder joint. So you can see how good of a picture that this MRI delivers. So you can see the bone, the muscle, tendons, etc. Okay, so I'm going to show some examples of how we use imaging to identify bone mets. So before I do that, I'm going to do just a little bit of anatomy. So this is the spine. Our spine has several segments. So we've got the neck or the cervical segment. We've got the thoracic segment, which is our back, and then the lumbar segment, and then our tailbone, our sacrum. And so each part of the spine, the bones of the spine, the vertebral bodies look different. And so this is an example of a neck bone, a backbone, and then a lumbar spine, so lower backbone. So if we look at this picture, what you can see is nerves travel all the way from our brain down the spine. So they travel through those little holes in the bone, in the vertebral bodies, and then they send nerves out. And the reason that that's important is because when we're doing imaging for bone mets, we're worried that the bone met is going to somehow impact some of the nerves, for example, the spinal cord, okay? So what could happen if a tumor impacts the spinal cord and pushes on the spinal cord? Does anyone know? What? Paralysis, exactly. So, and this can be an oncologic emergency, so we have to do something very quickly. So this would be an example, if we look at that vertebral body, of a tumor that's in the bone, it's gone to the bone, and it's now pressing and pushing that spinal cord over to the side. And so let's say a patient comes in and they have back pain, and they say, okay, well, we're gonna get, it's an upper back pain, we're gonna get an x-ray. So they get this x-ray. It's not really that helpful, okay? PET scan, that might be helpful. You might say, okay, well, I see maybe in some of the vertebral bodies there, it's lighting up. So you might have a tumor there. So, you know, that's helpful to know, I guess, but do you know if it's causing problems with the spinal cord? Uh-oh, what's happening now? It went away again. It says it stopped sharing. They need to reshare it because it's still on there. I think we just need to go back to the top. Oh. No? Now try what? Share the screen again? Is that good? Okay. Maybe. Okay. So now we're going to look at a CT scan. So before we looked at that big piece of bread slice, now we're just looking at the back of that piece of bread where your spinal cord or your spine is, okay? So this is that vertebral body there. You can see there's something wrong with the bone. It's kind of amorphous, but you really can't see the spinal cord, okay? So that's a CT scan. So this is an MRI. So what's interesting about this is you can see, I don't know if this is gonna work, but okay. So right here, so that's gonna be cerebrospinal fluid, that white area, and then this is the spinal cord where this red dot is, and this is all tumor right here. And so this is telling us that yes, in this scenario, there is tumor pushing on the spinal cord. So you can see that a lot of different imaging gives us some different information. But in certain scenarios, some imaging is better. So for spinal cord problems, an MRI is better. Okay, so another thing that is important when you're either looking at your own imaging or somebody else's imaging is to understand a little bit about these reports that come out, because now all of the radiology reports are sent out to the patient usually within 3 days. So a lot of times there's complex medical jargon in these reports, so it's really important to look at that, and then you can ask your doctor, what does this mean? The most important part of these reports is going to be the impression. That's like the summary. Like, what does all this mean? What does it compress down to? So this is just a generic report for a lumbar spine x-ray, so it's going to be really small. A lot of reports, like a PET scan, are going to be very complex, so something like this. So again, the most important thing is looking at the bottom part where it summarizes what the main issues are, but then if there's other issues, certainly talking about it with your doctor. Okay, so going back, so we've done the first part of the talk. Second part is, what do we do if we know that there's bone mets, or how do we prevent bone mets? So again, bone mets develop after cancer cells travel through the bloodstream and get to the bone. If we look at bone, and this is a pretty busy slide, but what it's basically saying is bones turn over. So there's two main types of cells. There's osteoblasts, and they build bone. There's osteoclasts, and they destroy bone, okay? So build and destroy. And your bone is constantly turning over. So when we do those bone scans, there is some low level of activity. But when a tumor comes in, there's going to be a lot more activity. Either you're going to get what's called an osteoblastic lesion, where instead of the bone turning over normally, it just keeps growing and building, and you have these really big, bulky, dense tumors. Or we have an osteolytic lesion, where you've got these osteoclasts which destroy bone, and they destroy a huge amount of bone and leave holes in the bone, okay? These cells, the osteoblasts and osteoclasts here, they rely on a lot of these these proteins, just like we were talking about in the last talk. One important one is rank and rank ligand. And so knowing that these cells, specifically osteoclasts, the ones that destroy bone, are reliant on rank ligand has led to the development of several drugs that use that to help prevent bone problems in breast cancer. So one example is going to be bisphosphonates. The most common one is going to be Zometa. So a lot of people have probably heard about this. I'm not going to go into a lot of details about this, but essentially these drugs, they block this rank ligand mediated osteoclast activity, and this is what ends up resulting in slowed bone resorption, increased bone strength, and reduced risk of fracture. So these are important in people who have been diagnosed with cancer, even if they don't have bone mets. A lot of times these are drugs that people will give. So this is just some basic data. Essentially, what it boils down to is that there is a reduced risk of skeletal-related events, so bone problems, when you are on these medications, and there's actually improved breast cancer mortality. And then if you look at this plot, again, all it's showing is that if the dots on this side of this plot, this is a forest plot, it means that bisphosphonates are better. And so you can see along the course, it looks like for most of these factors, your outcomes are improved with bisphosphonates. Mainly this is going to be in older women, so postmenopausal women. Okay, so the other drug that I'll talk about is denosumab. So this is a little bit different. It does also inhibit osteoclast function, but it does so through antibody. It's an antibody. So it actually binds and inhibits rank ligand, and it has similar types of effects. And so studies with this drug show that it improves your disease-free survival. So the red line on the top will be those patients taking this drug. It also improves bone met-free survival. There is some data, this is overall survival. There is some data that tried to compare the two. I would say from my reading, they seem relatively similar, but they try to make some, there are some areas where denosumab outplays the bisphosphonates. So, but really it's by a few months. So I'm not sure, I don't prescribe these drugs, but I think that overall they appear pretty similar. So those are the big drugs that I was tasked to talk about. And so if you look here, just like we talked about in the last talk, we're constantly coming up with newer therapies based on a lot of these molecular players. I only talked about these two players here, but you can see that there's a lot of other things in the pipeline and things that are available specifically to target bone mets. So now for the interesting part of the talk, radiation. So I'm just joking. So that's what I do is radiation. So this is a radiation delivery machine, okay? So the technology we use is X-rays for the most part. X-rays are the same thing that are delivered when you get an X-ray, like a chest X-ray. We just deliver lots of them in really high energy X-rays, and they kill cancer cells, okay? So There's a lot of different algorithms we use to find out who's going to benefit, who do we need to offer radiation to, but you can see a lot of roads lead to radiation, okay? One question is, do we need to do radiation even if the patient doesn't have symptoms? And there's newer data that is now showing that in patients who have bone mets, doing radiation, if they have high-risk bone mets, is actually beneficial, both in terms of reducing skeletal-related events, but also improving survival, this is a newer study that's come out within the past year, so 2024. So this is a radiation delivery machine. Now, I want to know, do you think it's a, yes, does it work? Okay, so this is a radiation treatment machine. So right now, what this treatment or machine is doing is it's actually imaging the patient. So when we have the patient on the machine, we want to image, make sure that we're targeting the right area. This is obviously not a breast tumor because this is the video that I found. This is likely a prostate tumor. However, it's very similar for a breast tumor, okay? So once we have made sure that we have the patient in the right position, that's when the machine turns on and delivers the radiation. It's painless to have radiation, so people come into the department, leave the department feeling the same. There are certainly side effects, but the procedure itself is not painful. Okay, so I found this video, and I'm hoping this plays too. This is the video from the perspective of someone who's receiving radiation. So this is the machine moving around them. So this is what somebody would see. And again, there's not going to be pain. They're not going to be feeling anything. And what this is doing is it's targeting our treatment specifically on the area where there is a bone met in regards to this talk, or whatever tumor that we're targeting. Okay. So just some other examples. This is a lesion in the arm, so kind of like the one we saw before. Again, we looked at different types of imaging. So what is the imaging on the left? Who knows? X-ray, good. What about on the right? MRI, man, okay. Are you guys in what, college or high school? Good job, okay. So this is, in addition to radiation, there's surgical interventions that we can use. And so in this example, this person has had a pretty major surgery where they go into the operating room, they put a pen into the humerus to stabilize it, okay? And then they put all of these screws in to attach everything together. So in this scenario, this patient would still benefit from radiation because this surgery did not remove all the cancer cells. So we would, in this case, have this patient come in, we would design a radiation plan, and we would target treatment for that area. I don't know what this is, don't worry about that. Okay, so essentially there's a lot of different thought processes that go into deciding what treatment is best for a patient. Do they need surgery? Do they need radiation? Do they need neither? One of these is if a patient were to have like a spine met, look at all these different factors that we can look at to determine whether or not this patient would benefit from a surgery, or if we can take them straight to radiation, or potentially neither. One intervention that can be done that's minimally invasive for a spine met would be a kyphoplasty. And so in this procedure, either an orthopedic surgeon, a neurosurgeon, or an interventional radiologist can put a needle into the spine where there's a lesion. And so in this example, you can see on the left that the the vertebral body has collapsed because there's presumably tumor there. So what this person is having done is they have a needle put in, they inject cement. We call it cement. It's not actual cement, but it does solidify the bone and help stabilize it. And then it brings the bone back to a more normal architecture. A more invasive type of thing that can be done with surgery is something like this, where they would have spinal cord stabilization. So in this example, somebody's, if you look at on the top left, that lesion in the vertebral body is too extensive. So you're not going to be able to just put cement in there. That thing is going to just collapse. So what they do is they actually put reinforcement on top of that lesion and the bottom of that lesion. And so a person is left with quite a significant amount of hardware in their spine. Still, this person would also need radiation therapy. I'm not going to go through this, but essentially a lot of studies have shown how important radiation is after surgery, okay? So this would be just some examples of what a type of radiation for a spine would look like. So now we're looking at the bread slice picture where we have a lesion in the spinal cord, in the vertebral body. And so what we do when we design radiation plans is we ensure that the area that we want to treat is getting the dose of radiation, but we also want to avoid radiation to things that we think are important. So if you compare the left to the right, you can see that the spinal cord itself is getting a lot of radiation in this plan, as well as the structure that's right in front of it, which is the heart, okay? In the plan next to it, you can see this is a lot more sophisticated plan. We've shaped the radiation around the vertebral body where the tumor is, and we're avoiding treatment of the spinal cord and the heart. This is another example of a lesion in the leg, so the hip/leg. And so in this example, what you can see on the far left is an abnormal x-ray. They've then put in a nail through the femur and they put some screws in, but unfortunately that hardware has failed. Hardware sometimes fails when the tumor keeps growing and it can't hold everything together. So again, it's very important to still do radiation even after you've had this surgery. And so this is now on the other end, a more extensive surgery where they've replaced the entire hip and femur. Okay, so this is the last slide. So again, mostly I want you to understand imaging is really important. You're gonna have imaging, your family is gonna have imaging. It's important to understand what it means, why you're having certain tests done, and how to interpret it. You're gonna have those reports, and so it's always good to ask questions. And then, understanding bone-directed treatment. So we have drug therapy, we have radiation therapy, and then we have surgical therapies. And hopefully in the future, we're gonna have even better therapies, and maybe even cures where we won't have to even worry about this. But that's it.
Do we have any questions?
So, hi, I'm Casey.
Hi, Casey.
Towards the beginning of your presentation, there was a picture of a tumor in the spinal of an MRI. So that tumor is like a dark black density. If that was not there, what color, what space would be left?
If the tumor wasn't there, what would the normal
Yes.
bone be? So that's a great question. So what we do with imaging is we try to look for differences. So it doesn't really matter if it's white or black because we can switch colors. So we're looking for differences. So in that sequence, they have made the tumor look a certain color and the bone look a certain color, but we can make them any color that we want. So for example, if the bone in that sequence was supposed to be white and they've made the tumor black, that would be one way to look at it, but sometimes it's flipped. Does that make sense?
Yeah.
Yeah.
Thank you.
No other questions? You guys ready to go home? It's been a long day.
Well, we have one more session that they are meeting at break, but we have one more session after the break. So if there's no more questions, we'll have a break, short break, and then we'll do our last session. Thank you.
Also, the Derby City Gaming.